Hey, what's up, guys? This is going to be a shorty on how to navigate brain bleeds. So in trauma, honestly, the majority of trauma is pretty simple, but it does get pretty hairy when you start getting into neurology, okay, and some of the chest questions too. But this seems to be a big topic, so we're just going to go over the big three, and um, and then I'll hit up some questions at the end. So let's get started. Okay, so the big three, the epidural hematoma, the subdural, and then the subarachnoid. The other guy that you could throw in here would just be the simple cerebral bleed or the intercerebral bleed. But if you get a question like that, just think about it as it's a stroke question, right? It's pretty simple. Pretty simple. Just treat it like a stroke, okay? But these three things, I call these the big three, and that's because when these three things come up, um, essentially you got to pick between the three. They're going to give you a scenario based type question, and then you simply got to pick between the three. And it's like, okay, well, how do I do that? So step one is going to be, well, let's look at what it is, right? So the first thing is when you think about epidural versus subdural, it's where is it in relation to the skull and the meninges? Okay, so simply the meninges is it's three layers. It's the pia mater, the arachnoid, and then the dura mater. Okay, so the mnemonic we use is pad, right? And the P is on the bottom. Okay, so the pia mater literally lines the brain. It's a very, very thin layer. And then above that is the arachnoid layer, which is very important. And then above that is the dura mater. And dura mater, they call it that because dura literally stands for tough. And it literally is the biggest fibrous cushion. Really, that's what this is. The meninges is literally just a cushion to not only suspend the brain but to protect it. Okay, and in the cranial vault, you got to think there's no room for improvement. There's no room for anything else. If the brain could move around, we'd all be dumbfounded. Every time we got a little coup contre coup. Um, but it doesn't move, right? And these layers help it not only get blood supply, not only get rid of any waste product, but it also protects it. So these three bleeds, and that's all they're asking, like where's the bleed and why do we even care? And it's the signs and symptoms will differ. And that's where the questions come in. So you have to be able to literally differentiate. So, I mean, let's get started. Let's start looking at these. All right, so the big three things to watch out for when you're trying to figure out what the answer is. Number one is timing. Okay, so I'm going to dive further into this, but honestly, you see a lot of differences with acute injury versus non-acute. So like the epidural versus the subdural. The epidural, they look at it as an acute injury because it is. Okay, the epidural is literally a blow to the head, and that's where it's severe enough to disrupt an arterial bleed, so you're symptomatic instantly versus like the subdural usually takes a few days to start kicking in. It's a very slow, it's what you call like a bridging venous bleed, so it takes a while. Um, and then also the arachnoid, is more specifically the subarachnoid. Okay, and the reason they kind of focus in on that subarachnoid, not just the arachnoid space. And if you think about the word sub always means like right below, right? So in this case, you look at the arachnoid space, it's literally the space that is at the very, very bottom of the arachnoid space, right above where the pia mater is, and that's where all the important stuff is. Like it's where the majority of the vessels are. It's where the cerebral spinal fluid is. So that's why they always say it's a subarachnoid bleed and not just an arachnoid. But typically, what's important about that guy, it's usually non-traumatic. Okay, so if you have a traumatic incident, I wouldn't be searching for I wouldn't be searching for a subarachnoid answer. Okay, and then pay very close attention to descriptive language. Okay, when they start throwing things out there like worst headache of my life, or they use the term lucid interval, they're searching for a very specific answer. Okay. Um, and you'll see like they'll throw ages in there too. If they throw in an elderly person or an alcoholic, then they're searching for the subdural bleed. So epidural versus subdural. These two get a little squirrely. Um, and it's like I said, timing is really important here. So the thing about this is sometimes they like to throw in this 24-hour timeline at you. And so sometimes you guys will go through your medic books and you'll read and it'll say, well, if the bleed is before 24 hours, it's most likely a epidural bleed. If it's beyond 24 hours, well, then it's most likely a subdural bleed. That's bull. That is total bull. I'm not saying that statement is wrong, but don't think that if it takes 23 hours or 22 hours for an epidural bleed to show up. That is not the case whatsoever. To understand the difference here, and when you get hit with a question, this part is very, very important. To get an epidural bleed, you have to have a blow to the side of the head. Okay, and that kind of brings the second bullet point in here. It's where did they get hit? And if you get a question that says your patient was hit on the side of the head, that's very descriptive. That they're most likely searching for the epidural bleed. So the thing is you have an artery that literally runs up the back of the head, okay? And it's called the middle meningeal artery. And to disrupt and get a epidural bleed, you have to disrupt that artery, okay? So think about that. You have to get a blow to the side of the head significant enough to disrupt that. You're looking at an open skull fracture, you're looking at a depressed skull fracture, okay? So think about that. Somebody got a blow to the side of the head so significant where they got a depressed skull fracture. When do you think you're going to see signs and symptoms for that? It ain't going to be tomorrow. That's what they're getting. So when they say this 24-hour timeline, don't think that like there's a hard line in the sand, 24 hours, that's not the case. This person got a blow to the side of the head so severe that it disrupted an artery. And sometimes you'll see that too. They'll say, well, the epidural bleed is arterial and the subdural bleed is a venous bleed, which makes it slow. Yes, that's true. It is a venous bleed. It is a lot slower. That is true. But this dude got a blow to the side of the head where it literally depressed his skull fracture. And they'll also throw the term in lucid interval. Okay, so by definition, lucid interval is somebody who passes out and wakes back up and or continuously, right? And anytime they use the term lucid interval, they're usually searching for epidural bleed. Okay, that's because they got whacked so hard on the side of the head, they got knocked out and then woke up again, and they're calling that the lucid interval. Okay, it's not like, oh man, I got hit. Oh, 10 minutes later they pass out. That's not what they're talking about. Just so you know, that can happen in all of these. It can happen in the intracerebral, it can happen in the sub-epi, the subarachnoid, doesn't matter. That can actually happen in any of them. So technically any of them can have a lucid interval, but when they use the term lucid interval in a paramedic question, they're probably searching for the epidural bleed because that person got knocked out and then woke up again. That's it. Okay. Versus the subdural bleed, the venous bleed. Now these are little what you call like bridging veins, and it's exactly what you think. It literally bridges from one part to the other, and it's just a venous bleed. So if you think about it, a venous bleed, they get a blow to the side of the head. It can literally leak into spaces. It's harder to pick up on a CT, and it just takes longer. And honestly, even as a clinician, not even just talking about questions, these can be very difficult to approach because let's say that's the other thing is who usually gets these, and it's usually the elderly. Okay, so let's say you work in an elderly area, and um, it's not a far throw to say that a lot of these people have dementia. So, you show up and grandma's, a little out of it, and the family's like, man, she's more than out of it. Like, this isn't normal for her. Okay, so what is normal? And then you try to paint your baseline and see how far off. And the truth is she could have fell down 3 days ago and ended up with a subdural bleed, and you don't know until you get them into the hospital and scan them. But when they're making questions, that's literally how they're painting this picture. They're going, it's an alcoholic, it's a elderly person. This is over a long period of time, and by long I mean 2 days, 3 days, that kind of stuff. It's not like boom, epidural bleed, arterial bleed, fast, lucid interval, and then instantly symptomatic. That's a realistic look at this. Okay. So don't forget, is the trauma to the side of the head or anywhere? Did it take days or is it acute? Did they get knocked out and wake up? And then what is the population that we're talking about? Elderly, alcoholics, pediatrics. Then you're thinking subdural, okay? The other thing is the epidural. It is, think about it, a blow to the side of the head. That's significant. You can have other signs and symptoms with that as well. So you can also have a blown pupil on the ipsilateral side. So boom, they got hit. If they got hit on the right side, that means the right pupil will blow. Okay. And then you can get contralateral signs and symptoms of paresthesia or paralysis in the body. Okay. The subdural will not do that, especially, I mean, it's the brain. So of course it can do that. I shouldn't have said that, but in a test question, no, that's not going to happen. So here's my favorite, the subarachnoid bleed. Okay, here are some descriptive terms that they use with the subarachnoid that they don't use with anything else. The big one is the headache. This is the worst headache of my life. Or sometimes they'll use the term thunderclap headache. If they use that terminology, boom, that's your guy. Search in your answers for that. That's your guy. The other thing is it's probably non-traumatic. The other two are traumatic. That's kind of a freebie, right? Thanks. Usually associated with aneurysms. Okay. This is actually the majority of these guys, for some reason, end up being in what you call the posterior communicating artery, and it's exactly what you think. It goes from a bigger artery to communicate to other areas in the brain. Okay, it's literally just a connection. Okay, it's a cerebral arterial connection, and for some reason people are more prone to getting what you call berry aneurysms in those areas, and they call it a berry because it literally outskirts this little blueberry looking thing on one. It doesn't do like this outpouching like you see in some of the other arteries, but in the cerebral arteries, it does on one side of it or one spot. Almost think about it like it pokes a little hole in the intima, and you end up getting it almost like a balloon. It feels like a balloon on the outside of it, and they call it a berry aneurysms. But you got to think about what's there, and this is in the subarachnoid space. So it's fluid, it's vessels, and this is why they go horrible, horrible headache. It's acute too, by the way. It's out of nowhere. This is the other guy that's associated with photophobia. Okay, so sensitivity to light, severe nausea, severe headache, and here's some weird ones. Okay, it causes a stiff neck. Okay, so if you think about it, person's got a horrible headache and a stiff neck. If they just gave you that in a question, like that screams meningitis. Okay, where it should differentiate is the fever. This should not have a fever, even though we all know, right, clinically, can you get a fever from this? Of course you can. You can get a fever from a heart attack. But in question land, no, that's not fair. They can't give you a fever with this. because that would be meningitis. The other thing is you get some weird pupillary reactions, or I should say not pupillary, but eyeball react. You can get dilated pupils with this, but you get what they call a down and out pattern. So if the bleed is on the right side, on that same side, you get a what they call a down and out, and the eyeball literally goes down and drifts out a little bit. Now the eyeball, what's weird is the eyeball will still move. Like when you do an acuity test or a vision test with them, the eyeball will move, but it's sluggish. And when you so let's say it drifts to the right. If you try to make the eyeball move left, it will cause them pain. Sometimes their eyebrows on that one side won't work. Um, and then yeah, that's pretty much it with that guy. But non-traumatic, worst headache of my life, and more likely aneurysms, and then a stiff neck. So that's your big differentiator terms. If you see those, subarachnoid all day, guys, all day. All right, guys. So first question up: 24-year-old male was involved in a high-speed motor vehicle collision. Okay, so traumatic. So that kind of x-nays the subarachnoid, right? So on arrival at the scene, he is conscious and alert, but complains of severe headache. Okay, so that could be subarachnoid, right? While being transported to the hospital, he is progressively drowsy and unresponsive. Okay, his pupils are unequal with the left pupil dilated. So sounds like epi, but again, still could be subarachnoid. Pupils are unequal. You suspect epidural hematoma. Okay, there you go. Which of the following statements about epidural hematomas are true? A. Epidural hematomas are typically caused by venous. Nope, can't be venous. They often present with an initial period of unconsciousness followed by lucid interval. That's probably your guy. The most commonly occur over the frontal. Nope, that's not true. Epidural hematomas, remember guys, on the side, not the front. Epidural hematoma is typically caused by lateral pupillary dilation. No, it's unilateral and it's usually ipsilateral on the same side, right? So B, that's got to be our guy, right? Absolutely. Next. So 72-year-old male patient presents with a fall from a standing height without even reading any further, guys. 72 years old. So you have an elderly male who fell from standing height. What is that? It sounds like subdural, right? He is on anticoagulant therapy, probably subdural. For AFib, exhibits confusion and a gradual decline. So gradual also says epidural. Mental status over 24 hours. Okay, it screams epidural at this point. Which of the following best describes the likely pathophysiology of this condition? Bleeding into the epidural space due to, nope, venous bleed between the dura mater and arachnoid. Okay. Cerebral edema causing ICP. Oh. And brainstem herniation. No, that's a whole other ball game. So what are we thinking? Dun, dun, dun. There she is. Venous bleeding between the dura mater and the arachnoid space. It's got to be it. There's your subarachnoid. Or I mean, there's your subdural hematoma. 45-year-old female presents with sudden severe headache. So non-traumatic. There's your subarachnoid. Oh, and there's your terminology. Worst headache of her life. It's subarachnoid all day. Nausea, vomiting, photophobia. Man, like this, it's a freebie. This is stiff neck. I don't even need to read anymore. There's only one thing this could be. So, given the presentation, which of the following is the most appropriate initial treatment by the paramedic? Most appropriate. Again, I've said this in my other stuff. Read your stems carefully. If you don't know what a stem of a question is, it's the very last part. It's literally what they're asking you. What's the most important? What's next? What's the, that kind of stuff. You got to pay very close attention to that. So here it wants to know what's the most appropriate. Administer naloxone. Come on. Establish IV access and monitor for signs of ICP. That's not bad. Administer aspirin for a suspected bleed. No. Perform hyperventilation with a BVM. I'm going to do another video on brainstem herniation because this is the other tricky one. I will tell you that anytime an answer says the term hyperventilation, don't pick it. If we get into brainstem herniation and it does actually have the signs of brainstem herniation, only pick an answer that ever says controlled hyperventilation, okay? And make sure you've read the up-to-date stuff on it. We used to hyperventilate somebody with Cushing's. We don't do that anymore. So the criteria to meet brainstem herniation has changed over this last 5 years. So it's got to be B. The other ones they just don't fit. Okay. There you go, guys. I hope that helps. And yeah, study hard.